Right, well I'm a stunt doubling really for Matt Hickman, who would have given a much better presentation than me. So I'll whiz through quite a lot. There are some acknowledgements which I won't read to you, but they'll be available on the presentation. Really, we've already seen the aim is to support the development, commissioning and evidence-based services to improve the health of people dependent on drug and alcohol. And people dependent on drug and alcohol are kind of focused in areas of greatest deprivation, and you're unlikely to find a population who suffer greater health inequalities, because not only do they suffer the normal health inequalities of people that live in those environments, but they're non-health seeking generally, and therefore they're often iller and less likely to access services than the general population. The ad hits a really rich soup of all of the usual suspects. So we've got services, commission services, community groups, we've got service users, academics, Public Health England and other interested bodies. So it's a really good space in which to do some thinking around this. And I think that one of the main advantages has been in drawing in funding for research for the ad hit. And really I think it's the combination of all of those people in the room together that make a much more rounded funding application than you'd get if individual bodies were applying. I think you'd agree, Maggie, that actually having everybody doing that together collaboratively is really helpful. And I'm hoping Maggie's going to pick me up on anything where I stray off piste here. So if I say anything untoward, I'm hoping you're going to help me out. So a couple of bits of research I want to focus on. One is around the use of low dead space syringes to decrease bloodborne virus prevalence. And the other is around some research we're doing on MRSA and injecting drug users. So the low dead space syringes really are nice and WHO recommended for needle and syringe programs. And really we wanted to look at the best way of introducing these, because one of the things we didn't want to do was introduce a new syringe without consultation with service users and suddenly find we've got an unintended consequence of less people taking needles, for example, and that would then increase the rate and risk of the spread of BBV, and certainly with this population, injecting hygiene isn't top of their list when they're injecting. So two things to the advantage really is, one is that I'm going to whiz through this because I've got far too many slides. One of the advantages of this type of technology is that the user gets the entire syringe content, but also that there's much less chance of onward passing of any blood products between individuals who may share needles. So one of the things that we looked at in terms of the anticipated responses to the introduction of this was that there might be some initial annoyance, which isn't really a problem. People generally be willing to try them and then become accepted, or there might not be any response at all. But we wanted to be clear that what we didn't want to do was upset the apple cart and do anything to disincentivise people collecting clean needles to inject. Again, all of this will be made available. So the two real big important features, and certainly some of the feedback we got is that less waste isn't obvious, but nobody wants to waste anything in life, but drugs, since it's their obsession, is the most important thing. So the drug user priority really is about getting the drugs into them. It's not necessarily about, they're not thinking of their long-term health when they're doing this. And so we can talk about them all day long about why this is a great advantage in terms of the reduction of bloodborne viruses. Although it's something they're concerned about, at the point of injection, it's not the thing that's at the forefront of their mind. But certainly it's really helpful to have a piece of equipment that delivers the entirety of their syringe and has the added benefit of preventing the spread of BBV. So, and there's some interesting quotes from service user interviews within that. So really where we got to was a preference for a gradual introduction of the technology, but certainly do it, give service users the choice, so that we could extol the benefits of the new needles, but people would still be free to choose, and hopefully then introduce them, and gradually people would select hopefully the more favourable technology that will reduce both their risk and enhance their using experience. So needle exchange is just a really hugely strongly evidence-based harm reduction intervention. We've got some of the lowest rates of bloodborne virus transmission amongst injecting drug users anywhere in Europe, and indeed the world, and something we're really eager to hang on to. We're beginning to see some increases in HIV across the city, and that's reflected also within this population. And so anything we can do to reduce the onward transmission of bloodborne viruses is really important. But it's also really important that we do this in an organised and constructive way that doesn't have any unintended consequences that I was talking about. So lots of recommendations for the implementation. Training for the staff for needle exchange, about selling the benefits and identifying the target audience. Education for drug users around the benefits of the technology, and gradual introduction and an opportunity to try the new equipment rather than just switching them over and having people vote with their feet, which is clearly a very unintended consequence, and then monitoring adverse effects and long-term outcomes. The other piece of work that's interesting at the moment is around MRSA infection within injecting drug users. It's in what feels like a really significant increase in MRSA bacteremia, and although rates have generally decreased, what we've seen in this population, it's gone from about 1% of infections to about 26% in the last 4 years. And there's just something going on that we're not really clear about what's happening with the biology, behaviour and environment of these individuals that make them at greater risk of developing bacteremia, but there's clearly something going on. And before we design an intervention, we really thought it was important to understand the context so we get the right problem for the right solution. People immediately leap to solutions, and actually we might be spending a lot of money, particularly at this time, in deploying an intervention that may not at all hit our target audience, because what we might be doing is improving the life of people that are already careful about their injecting practice, but this group, who are generally very, very ill by the time they reach us, as I say, are probably not the people who are most concerned about injecting practice and wound hygiene. So the prevalence of MRSA in injecting drug users in terms of colonisation, so carrying it on the skin and nasal passages, is higher than the general population, but we don't know exactly what that looks like, and we don't know what it is about the biology, behaviour and environment that makes them at greater risk of developing bacteremia. So as I said earlier, really injecting drug users counted for 10% over the 4-year period, but it started off at 1.1% and it's gone up in 2014 to 26% of cases, and that feels like a very significant change over a very short period of time. The majority of injecting drug users have got MRSA isolates from their skin and soft tissues, and a third of those have got bacteremia. And at least 14 of those have been detected on 2 or more occasions between 2006 and 2014. So 50% of those, the injecting drug users with MRSA isolated, had a history of homelessness. 84 of them had a history of concurrent heroin and crack use. And I think there's something in that, because we're just seeing crack use appear in Cornwall volume, and we're also seeing reports of MRSA in Cornwall for the first time. This is kind of new information that we need to just take stock of and have a look at, because there may be something in the combination of those 2 drug types which is kind of unique to Bristol in the southwest. Bristol's got a very different makeup of drug use in the southwest to any other local authority area, and that's probably about supply chains and supply routes. But as those are changing, we probably need to take account of that and how it might impact on things like bloodborne virus infection and particularly MRSA. 12 of the 14 cases with groin injectors, and it does seem that groin injectors are particularly at risk, and a number of them had a history of deep vein thrombosis, and I'm assuming that's opiate substitute treatment were noted amongst the majority in the patient in the post-infection reviews. Okay, that's fine. So I'm going to whiz through some of that. So there's other stuff that we're looking at the moment. I think the AdHit is currently going through a review of what it does and how it does it. That's really timely given all the things we heard earlier. And I think it's been a bit of a curate's egg in that it's been good in parts. There's some bits of it been working really well, and other bits where kind of not necessarily, as somebody earlier said, not necessarily all the right people on the right bus. So there's a degree to which we need to just kind of review and really focus and improve our outcomes. But I think there is a rich stream of research that we've got in chain, and I think there's some really interesting stuff happening. So systematic review of malnutrition of alcohol-dependent people, feasibility study to reduce drug use in street-based sex workers, evaluation of the South Gloss opioid analgesic dependency project. The other things we're thinking of looking at in the future is looking at combination therapy really for opiate substitute treatment to maximise the benefits and reduce mortality amongst people who are on opiate substitute treatment. How to improve hepatitis C case finding in primary care and specialist drug clinics, investigate cost effectiveness needle exchange, pilot trial of alcohol screening and brief interventions, scope health impact assessment of licensing policy, and that's interesting for Bristol. So how we use licensing policy and cumulative impact to affect better controls, and I think there are some real opportunities in how you restrict alcohol licenses by using health outcomes, and there's some really interesting stuff that's come out of a national pilot that I think we can take into account, and a systematic review of alcohol detox between hospitals and residential programmes. And that's it. So,
thank you very much.
Thank you very much.